key things that our kids go through. So welcome, Aaron Besterman.
Thank you, Susan, for that really sort of heartwarming and I know difficult story, but I think may resonate with a lot of families here, and is really important for families to know that there is help that can be found out there when you're facing these very challenging situations with your children. So the talk that I'm going to give today is generally somewhat generic. It's not specific to Smith-Kingsmore syndrome because, as everyone I think in this room has learned at this point, right, we don't have any proven treatments unique to Smith-Kingsmore syndrome yet. And so the advice that I'm giving would apply to any kid with a neurodevelopmental disability who is presenting with challenging behaviors. And this is actually a talk adapted from the talk that I give my child psychiatry fellows. You know, this is what we learn as physicians as well. Oops, let's see, can I advance it? Oop, somehow, there we go. I think I got it, thank you. So before we jump into medications, I think it's really helpful to go through a little bit of a definition, a dictionary of what a lot of terminology means, because you're going to go to doctors' offices and psychologists and other clinical professionals, and people are going to throw around all of these different terms, and it can get really confusing. It can get really confusing for doctors, and honestly, reading through thousands of charts and notes, I see these terms used incorrectly all the time by clinical professionals. So it's totally understandable that parents and families may be very confused as well. So just to make sure that we're all on the same page, right, there's this term neurodevelopmental disorders, and that can mean a lot of different things to a lot of different people. And you also hear the term intellectual and developmental disorders or disabilities, neurodevelopmental disabilities. Generally speaking, all these terms mean the same thing and are used interchangeably, which is very confusing. So classically, when people use this term, neurodevelopmental disorders, they're referring to one of three conditions: global developmental delay, intellectual disability, and autism spectrum disorder. And those may or may not be associated with a specific genetic condition. You can have a neurodevelopmental disorder regardless of whether or not the genetic underpinnings of it are known or well defined. Right? So when you hear the term neurodevelopmental disorder, it's generally referring to one of these three. Sometimes people would also include ADHD under that umbrella, right? Because we know these disorders occur at a very young age, right? It's a disorder of brain development, of neurodevelopment. So sometimes people would also include schizophrenia even, because we know the onset is actually very early on, right? So, but generally speaking, this is what people are referring to. So what is global developmental delay? Very generally speaking, It's when a child does not meet their developmental milestones on time across multiple domains, right? So it's not just a language delay or just a motor delay, but when they have delays across the board in language, motor, social, cognitive skills, more than one. And this is a very confusing part that clinicians often get wrong. By definition, this is an arbitrary definition, it can only be a diagnosis for kids under the age of 5 years old. Once you're over 5, this diagnosis no longer applies. And the theory behind that is, at that age, we can do reliable testing for intellectual disability. So a decision should be made whether or not your child meets criteria for having intellectual disability or not. And then this label of global developmental delay goes away. You can have a history of global developmental delay at that point, but technically, over the age of 5, you can no longer have a diagnosis of global developmental delay. Intellectual disability refers to deficits in intellectual and adaptive functioning, right? So a lot of kids who have global developmental delay go on to then meet criteria for intellectual disability. And that requires formalized testing for IQ and adaptive functioning. Adaptive functioning meaning being able to do activities of daily living, dress yourself, brush your teeth, put your shoes on, those sorts of things. There are different levels of severity of intellectual disability. Typically, it's divided into mild, moderate, severe, and profound at different cutoffs. Doesn't matter all that much about the specific numbers, but just to give you some familiarity with the terminology that you might hear when talking with doctors or other clinicians. Autism is not the same thing as either global developmental delay or intellectual disability. And this may be the most confused point by a lot of parents and clinicians. There is high, what we call co-occurrence, meaning a lot of kids who have autism also have intellectual disability or also had a history of developmental delays, but they are fundamentally different disorders. Autism, fundamentally, is a disorder of social communication, meaning there are impairments in the way that kids communicate with others socially and their understanding of social cues. There's also another core component of autism, which are called restricted and repetitive behaviors. We all know that kids with autism tend to have very rigid mindsets. They can be very hyper-focused on certain things. It can be very difficult for them to shift from one task to another or one interest to another. Sometimes they might have physical repetitive behaviors like lining things up or hand flapping or other sorts of repetitive movements, right? So fundamentally, autism is a disorder of social communication tied with restrictive and repetitive behaviors. Those individuals may or may not have intellectual disability. It's somewhat split, and about half do and half don't. Those numbers vary depending on the studies you look at, but ballpark about half do and half don't. Some kids with autism even have an IQ higher than the population average. So you can have autism without having intellectual disability. I added this slide, and the reason I did is because you might start hearing about this. This is a newer term that was literally created about 5 years ago by a group of autism experts called Profound Autism. The reason why this was created was that there was a lot of discourse in the autism community about what's the right way forward and how do we think about autism? Do we think about it as a difference, as sort of an identity, right? We're just a quirky group of individuals who are a little bit different with some social challenges, or do we think of it as a disorder, right? And it basically, the way that people were advocating really sort of seemed to split down the line of those with co-occurring intellectual disability who thought of it more as a disorder because there was a lot of disability associated with it, as opposed to those individuals who did not have intellectual disability who felt like it was more of an identity and personality trait. And so in order to help distinguish those two groups with and without intellectual disability, this new term was created called profound autism, which really encapsulates those individuals with both autism and intellectual disability, with a lot of associated disability. And so if you're hearing about fundraisers, or there's a Profound Autism Alliance that does a lot, that's very active these days. This is where that terminology comes from and what people are talking about. Just very quickly, to make an autism diagnosis, we can do it clinically. I do it all the time in my office. It's not absolutely required to have psychological testing to have an autism diagnosis. It's a clinical diagnosis that there's criteria in the DSM, the Psychiatry Bible, that you can make a diagnosis based off of someone meeting sufficient criteria. However, there are a lot of insurance companies and other sort of providers, if you will, and people in the healthcare space who say we will not accept that diagnosis unless they have the gold standard evaluation of these two tests known as the ADOS and ADIR. That there are one is a direct assessment and one is a survey that needs to be filled out by parents, and then you put the scores together and you make a diagnosis or not. So can a diagnosis of autism be made without the ADOS and ADIR? Absolutely it can, and if people tell you otherwise, it's wrong. But do some institutions or providers require this testing for a diagnosis? Some will, just so you're aware of how the system functions. And I can't really speak to other countries besides the US and whether this is required routinely or not. But it's labor intensive, often expensive, and there's usually very long waits to get this testing done because it takes a lot of time. So now we'll sort of dive in to the challenging behaviors. So when you hear challenging behaviors, in general, there's a few exceptions to this. What we're talking about is something known co-occurring psychiatric disorders. So these can be things like anxiety, like depression, like bipolar disorder, like schizophrenia, or sleep-wake disorders. And then one that Susan's alluding to, right, is aggression, or which is also known as agitation, or irritability is often the labels or terms used in the context of autism, especially by the FDA when they're thinking about approving medications to treat these symptoms and behaviors, right? So when you hear about challenging behaviors, what people are generally referring to are co-occurring psychiatric disorders. And I add this slide here because when us as doctors who manage these sorts of challenging behaviors, one of the first things that we always need to be thinking about, that you should be thinking about, that your doctor should be thinking about, is what is the underlying cause, right? You can have violence, aggression, and it's not all the same from one kid to the other, right? There could be one child might become aggressive or agitated because they have high levels of anxiety. That's the underlying cause of their agitation. Other child might become aggressive or agitated because they have dental pain, right? And they maybe have limited verbal communication or limited communication generally, and they can't express that or communicate that. They might have constipation and stomach pain. So it's always critical that if your child has limited ability to communicate their physical experiences, right, that the doctors are thinking about maybe perhaps there's an underlying medical reason. It's not an underlying psychiatric reason or mental health reason that there is a concerning behavior, but there's actually a medical reason, and that should always be considered, including seizures are another potential underlying medical cause that can result or manifest in changes in behavior. And so these things should always be considered. Now, this is sort of the key question that so many families come to me about, which is, great, now we've recognized them, you know what's going on, what can we do about them? How can we help our child? How can we make these behaviors better, so they're not suffering as much. They don't seem as distressed and agitated or depressed or anxious, what have you. And also, our home is safer, right? Our home is calmer. It's a place of peace and not an area of an environment of stress and concern, right? And so, before we even consider medications, everyone should know that there are behavioral interventions. Most of you have probably heard of applied behavioral analysis, or ABA, which is the gold standard of treatment for kids with neurodevelopmental disorders, was developed for autism. Your child does not have to have a formal diagnosis of autism for these interventions to be helpful, because the same principles of how you identify a problem behavior, develop a behavioral plan to try to address the underlying cause and reduce the behaviors, can be used and be helpful for kids with a large range of neurodevelopmental disabilities. But they were developed originally for autism. So in the United States, part of the reason why autism diagnoses seem to be on the rise, you can't get these interventions covered unless you do have a formal diagnosis of autism. So physicians, clinicians are often very loose with their autism diagnoses to help families in getting these services that can be helpful, whether or not their child has a formal diagnosis of autism or not. There are now a new group of behavioral interventions that build on ABA. There's a lot of overlaps with ABA, but some sort of nuanced difference called naturalistic. I always have to read it because I can never remember the acronym. Naturalistic and developmental behavioral interventions, or NDBIs. And these are things, if you're reading about potential interventions, you'll read things like Jasper, the Early Start Denver model, Project Impact. These are all examples of NDBIs. And the slight difference is it tends to be much more patient-driven as opposed to provider-driven. ABA is really, the provider is the one who knows the plan, understands what's going on, and creates this whole sort of system of like sort of reward and punishment system to try to shift behaviors. NDBI tries to take aspects of developmental psychology, understand the child, let the child dictate to some degree what their interests are and how they would like to proceed in sort of a thoughtful way. And the therapist is more of a facilitator, and often there's more parent involvement in NDBIs, whereas the traditional ABA is much more sort of therapist-child focused. So I'm not going to go into all the details, but it's really to just bring awareness. This is something to be aware of. There are alternatives to ABA. It may be harder to find an NDBI provider. There are less of them. But there are behavioral interventions that can really help reduce some of these concerning behaviors. But if we try that and it doesn't work, or the behaviors are at a level where there's real safety concerns, you might not have the luxury of waiting, and you don't need to wait and try months of behavioral therapy before considering medication. And this is a conversation that you should have with your doctor, right? And I have this conversation every day with new families. Where are things? Do we have the luxury to wait and try behavioral therapy? How long is the wait to get a behavioral therapist, right? We have to talk about the realities on the ground. It's going to be 8 months before there's a behavioral therapist. We're not waiting, right? Is there real safety concerns at home? If there are, we're not waiting, right? There are also medications that can really help address some of these behaviors. And I'm going to quickly go through some of them. This is not an exhaustive list, and each medication decision needs to be between you and your doctors, and you need to individually weigh the risks and benefits of each one. So, right, as I was talking, anxiety is probably the most common co-occurring psychiatric condition in kids with neurodevelopmental disorders. I'm sort of using ASD as the poster child of neurodevelopmental disorders, just for discussion's sake, and also there's just the most literature out there, so it's just easiest to talk about. So this is what, for those not familiar, this is what's called a forest plot. And so basically it's a summary of all the studies that have been done on this one topic. And there's subsections dividing it by medication. And those middle line basically means there's no effect. If the diamond, each diamond is the summed effect for each medication. And if the diamond's on that vertical line, it means that there's no effect. If it's to the left, right, it favors medication. If it's to the right, it favors placebo, because these are all randomized placebo-controlled trials, right? So what you can see is if you sum all of the effects of all the medication, the diamond's slightly to the left at the bottom, which means that favors the medication as beneficial over placebo. And if you see the diamond for each subsection that's farthest to the left is for fluoxetine, which is Prozac. And that's consistent with neurotypical kids. The best medication for anxiety for children, and this does not apply to adults, both with autism and without, is Prozac. The other ones tend to be okay, although venlafaxine, that's a SNRI, won't go into all this, but that's Effexor, actually does not work very well. Again, consistent with neurotypical kids. But a lot of the SSRIs work quite well for anxiety. With autism, most notably is Prozac. So again, a discussion to be had with your doctors. There are many other options. I don't always use Prozac for a host of reasons. So it's important to have discussions with your doctor. Now, what about ADHD? Again, a very common co-occurring condition with autism. And how this can manifest is impulsivity. A lot of times, hyperactivity, impulsivity. And this is where we get really worried. Is your kid darting off into the street? Are they eloping from the house, right? This might be impulsivity associated with ADHD. And this can be really concerning behavior. I've had patients, not with SKS, but I've had patients and families where they literally build a wall around their house to keep a kid contained, right? If you're going to those extreme approaches, it is certainly worth considering medication if you have to build a wall around your house to keep your child safe, right? So do we have any evidence that medications work? Yes, we do. The same medications that work for ADHD and neurotypical kids, the stimulants, which are methylphenidate, Ritalin, and amphetamine, which is Adderall, can really reduce impulsivity and those associated dangerous behaviors. Here's just a study showing sort of the drop-off of hyperactive behaviors, pre on the left and post on the right. These are two parent ratings of hyperactivity and teacher ratings are the two lines. You can see both parent and teacher ratings show significant drop-off of hyperactive behaviors with the use of Ritalin in kids with autism. Now, if we're not sure about the underlying cause of aggression and irritability, and it just seems sort of out of the blue and spontaneous, what we might diagnose in the DSM as intermittent explosive disorder, there are actually FDA-approved medications, two of them. One is risperidone, and one is Abilify. These are of the class called atypical antipsychotic medications because they were developed first for psychosis, for schizophrenia. But they are used and FDA approved for agitation and irritability in people with autism. They're not treating psychosis, even though they're called antipsychotics. So the first line are these two antipsychotics, risperidone, Abilify, the gold standard. And if I'm really concerned about this, I always go to risperidone first. It just seems universally to work the best. Not for every child, everyone's different, but on average, that seems to be the most effective. However, this is something everyone should be aware of. While it is the most effective, it also has pretty significant side effects. And the major ones that we always run into, that we need to struggle with, is weight gain, significant weight gain, elevated cholesterol, and elevated blood sugar. These are not trivial. Kids can develop diabetes and have really elevated cholesterol from these medications and gain dozens of pounds. So it's a real risk-benefit trade-off. If it's between extreme aggression and violence and safety versus these medications. Sometimes the trade-off is really, really worth it. But if it's more mild, there are alternatives that may not work as well. And I would say the main alternative is alpha agonists. And this is 2 medications are in this family known as guanfacine and clonidine. And these are, they can be mildly sedating, clonidine more sedating than guanfacine. And they have many fewer side effects, are much safer, but tend to not be as effective. There's also, I'd say, third line agents. We won't go into details, but needless to say, there are many options, and not every option is the right option for your kid, and it's a discussion that needs to be had with your doctor about the risks and benefits of each. I will highlight one last thing. There is some evidence self-injurious behaviors can be something that's really hard to manage and very concerning when a kid is harming themselves. And there is some limited evidence that a drug called naltrexone can actually help reduce those self-injurious behaviors. So if that's something your child really struggles with, it's a good conversation to have with your doctor about this medication, because there's really, the other medications tend not to help reduce those behaviors that well. We won't go through all the detail, but needless to say, there's been trials of various medications for depression. Again, could be an underlying cause of irritability, aggression. Kids with intellectual disability can become depressed as well, right? Everyone has mood and emotions, and depending on what's going on in their life, they can feel down and depressed as well. And so it's worth considering, is there a lot of spontaneous crying? Have their energy levels shifted? Has their sleep shifted? Has their appetite shifted, right? These are all, can all be signs of depression. It can be harder to pinpoint that in kids with SKS and other developmental disabilities, because there can be alternative explanations, but it could also be due to depression. And again, fluoxetine, Prozac tends to rise to the top as far as the most effective, but there's many options. This is something that our SKS families deal with a lot, is sleep-wake cycle problems or insomnia. The good news is each one of these is a different drug class that's an option. And this is actually a review I wrote with a colleague a few years ago, highlighting a new class of medications known as the dual orexin receptor antagonist, or DORAs, like suvorexant. So that's a newer medication that actually targets the circadian rhythm pathway, as opposed to most of these others that are just general sedatives that just sort of knock someone out. That one's much more targeted, and we do have some anecdotal evidence from a couple families who've tried that new class of medication that it might be uniquely helpful for kids with SKS. In my experience, I've never treated a kid with SKS with that group of medications, but in this paper I described my experience treating about 8 other kids with neurodevelopmental disabilities, some of them with other specific genetic syndromes. We had about 2 kids who had remarkable responses, and it was life-altering for them, where they had not slept well their whole life and then slept completely normally for the first time in their life after trying this medication, suggesting there might have been a primary disruption to the circadian rhythm pathway. And then we had a lot of others who didn't benefit at all. So it's really, each kid's going to be unique, and there's going to be a trial and error process, and you're going to have to discuss with your doctor the potential risks and benefits of each one of them. But needless to say, there are a large number of medications that can potentially be helpful for sleep, and so don't think that you just need to sort of sit there and deal with it at home, because if you're not sleeping well, you feel terrible, and that's true for our kids as well, right? And so another thing to be thinking about as far as underlying cause of irritable behavior or outbursts, right? Is it due to poor sleep, right? And that's something that should be addressed at the beginning. This is something that's also, as Susan alluded to, there are some things that can be really hard to talk about, and something that sometimes families really hesitate to even bring up with their doctors because they're embarrassed. But some kids with intellectual disabilities especially, and neurodevelopmental disorders of all type, can have what we call inappropriate sexual behaviors. This might be like masturbating in public. This might be like groping or trying to touch people in public in inappropriate ways. And this can get really dangerous, as you can imagine. And I've had patients where really bad outcomes have occurred because obviously people in the general public don't understand your unique situation. And if your child gropes someone in public, that may not end well, right? And so I've had families who don't take their kids out in public anymore because of concerns about these behaviors, right? And so it's something you should be talking to your doctor about if it's happening. And there are behavioral interventions, and there are actually potentially medical interventions. There's one medicine called mirtazapine that's an antidepressant that has shown some decent evidence, and I've actually had some decent success with it. And then if it really becomes a problem, there are sort of more extreme interventions that actually target the hormonal system directly that we usually work with endocrinologists around. Most of the time, thankfully, we don't have to go there. But just to know, there are options to address these behaviors. And with that, I will wrap things up.